Oh, good morning, everyone, and welcome to Tuesday Grand Rounds. Our topic today is going to be long COVID and pediatrics, and it's a topic that I think is going to be very interesting to most of us because there's just a whole lot of divergent opinions out there exactly what it is. When we decided to invite our speaker a few months ago, I remember asking some of my general pediatric colleagues, like, do we have a speaker on long COVID in pediatrics? And one of them said, oh, yeah, we should, because we're just not seeing that. And then the same day I asked another one, and she said, oh, yeah, we should, because we're starting to see that. So this morning we have Dr. Daniel Blatt, and he comes to us from the University of Louisville School of Medicine and Norton Children's Hospital in Louisville, Kentucky. He's been an assistant professor of pediatrics there since 2020. He received his medical degree with highest honors at the University of Health Sciences in St. Kitts. During his time in Louisville, he helped to pioneer a post-COVID clinic, one of the first ones in the country, which is the reason why we've invited him this morning. And in addition to seeing patients in the outpatient clinic, he has a clinical focus on pediatric transplant, infectious diseases, and hospital epidemiology. Dr. Blatt has an interest in global health and malaria research and is a principal investigator for multiple clinical trials. He's an advocate for and active participant in community outreach and medical equity. Outside of medicine, Dr. Blatt enjoys outdoor activities, including ultimate frisbee and hiking, as well as traveling with his wife Meredith and their dog Jimly. And today he'll be talking to us about post-COVID syndromes in children. So without further ado, welcome Dr. Blatt.
Thank you so much for the kind introduction. I'm really happy to be here today. Let me just get this situated. All right. I know that we've all learned so much about COVID during these past 2 years, but today we'll be talking about something that we don't know a lot about. We will discuss what happens after the acute period of COVID is over in children. So let's start with the clinical scenario. A 13-year-old female presents to her pediatrician with concerns of headache, fatigue, and difficulty concentrating. She has had symptoms for at least 2 to 5 months and recovered from COVID about 3 months ago. She thinks that her symptoms worsened after COVID infection, but she isn't sure. She is worried that she may have long COVID. So she wants to know, does she have this disease? And she wants to know, will it get better? I'm pretty certain that most of you have heard of long COVID. Many of you have seen a patient like this and may already know the answers to these questions. The issue is the discussion. As a provider, we like to be a beacon of knowledge and guidance, but being a provider becomes harder when we are dealing with a complex disease of unclear pathophysiology. A disease without definitive testing, treatment options, or even a clear time course. What I want to do today is discuss post-COVID disease on a broad scale, and I hope to give you some insight into the experience our group in Louisville has had in our own clinic. Sorry, it's not advancing. There we go. So today we will discuss post-COVID unwellness, which goes by some other names like long COVID or post-COVID syndrome. We will talk about how did we get here, what is post-COVID unwellness, and what experiences have we had so far. Before we get started, let's gain a little perspective about what we are talking about. So I'm going to ask a question. What percentage of children have been reported to experience long COVID after infection? It's a bit of a trick question, but all of these answers have been reported in the last year or so. It looks like most people thought it was about 21%, but really there's huge variability, probably in part to the actual disease definition, and probably in part because long COVID may be difficult to diagnose and to monitor. So let's look into how we got into such a problematic phenomenon. 2 years ago, this headline was on the front page of the New York Times. China grapples with mystery pneumonia-like illness. This, of course, was referring to SARS-CoV-2. But before SARS-CoV-2, we've actually seen another coronavirus epidemic. In 2003, SARS-CoV-1, which resulted in 8,000 cases and almost 800 deaths, was considered to cause more fear than any other outbreak of the time. 2003 SARS was a wake-up call, and it led to a revision of the international health regulations and the development of the global health security agenda. When the 2009 H1N1 swine flu pandemic came along, there were many panels and recommendations created to improve pandemic preparedness. But all of that led to very little change, and most recommendations never made it beyond the paper they were written on. Since 2003, we've had SARS, swine flu, MERS, Ebola, and Zika to stoke preparation. But the global community continued to fail at this task. Now we are dealing with SARS-CoV-2 and COVID-19. We've seen more than 500 million infections and more than 6 million deaths. More than 17,000 healthcare workers died in the first year alone. This has been the largest hit to the global economy since World War II and the greatest economic contraction since the Great Depression. It has been due in large part to a lack of preparedness. And it wasn't that countries didn't think they were prepared, they just weren't. Country preparedness was assessed under the voluntary joint external evaluation process, which is an independent academic exercise. Here on the y-axis is death rate due to COVID-19. On the x-axis was the preparedness score calculated by a country's own internal evaluation metrics. What is shown is that the ranking of a country's preparedness did not predict the performance of those countries in the COVID-19 response. Highlighted in the green box, you can see that the US is far to the right and high on the evaluation score. But they're also high on the y-axis, meaning a high death rate. The measures implemented did not account sufficiently for the impact of political leadership, trust in the government, and the ability to mount a fast and adaptable response. All of that to say, the US scored high for being prepared, but still had a high death rate. So we know the world was not prepared. The inability to take preparation seriously, combined with population growth, environmental changes, and global travel, put the world at risk for a zoonotic infection to be introduced into the population. Which brings us to December of 2019. There was an unknown pneumonia in 41 patients discovered in Wuhan, China. Almost 2/3 of those cases had been in the Hunan seafood market in Wuhan. During December, it was unclear if the virus could be transmitted from human to human. By January 2020, it was clear that this is what was happening. On December 30th, 2019, the Health Commission issued 2 urgent notices to hospital networks about pneumonia linked to the seafood market. The market was promptly closed and cleaned. CDC Taiwan then alerted the WHO. Very quickly, by January 2nd, SARS-CoV-2 genome was sequenced and made public by January 11th. A PCR test was created by January 10th. On January 20th, the WHO went to investigate in Wuhan. On that same day, China confirmed that the virus is transmitted from human to human. And on January 23rd, China went into lockdown. But 10 days before the lockdown, Thailand had already seen their first case, and it had already started to spread. A public health emergency of international concern, or a PHEIC, is the loudest alarm that can be sounded by the WHO Director General. The WHO met on January 22nd and was split on declaring a PHEIC. The committee then met again the next week and recommended declaring a PHEIC on January 30th. At that time, travel restrictions were not recommended. Then on March 11th, COVID-19 was declared a global pandemic. Throughout this process, data sharing moved fast, but action to declare an emergency moved slow. The problem is that highly transmissible respiratory infections do not wait around for decrees of public emergency to be called. On January 30th, the spread of COVID-19 was limited to the darkened areas you see on the map. By March 11th, when COVID-19 was declared a global pandemic, the map became mostly red. COVID hit the US on January 21st. By the first week of March, it was doubling every 2.5 days. It wasn't until March 13th that the government declared the pandemic a national emergency. For many countries, it was not until they had already seen widespread local transmission and their hospitals were starting to fill with desperately ill patients that they finally took action. Healthcare facilities all around the world were not ready for such spread. Ambulances were waiting in line to reach emergency departments that were too full. And once in the hospital, patients had to wait in EDs as inpatient beds were in short supply. There are many examples of systems that were many times over capacity. As the pandemic developed, PPE became needed in quantities not seen before. The world needed 40% more PPE than could be produced. Remember back to 2 years ago when we were considering using homemade masks in hospitals. And PPE became expensive. The dark bars are pre-pandemic prices. The pink and the red bars are the average and maximum prices of PPE during the pandemic. High prices leads to loss of access, and loss of access leads to inequity. As you all know, healthcare wasn't the only part of society that had a problem to deal with. Almost 75 million people in the US at risk for severe COVID could not work from home. People had to choose between safety and being able to provide for their families. The darkened areas on the map show high rates of COVID-19 vaccination per capita, and the light areas are low rates. It is clear that rich countries were getting vaccinated at much higher rates than poorer countries. Even when within our own country, vaccine rates differed greatly based on demographics. Inequity has been magnified during the pandemic. Inequity is perhaps most easily identified by the nearly 125 million people who are now living in poverty directly as a result of the pandemic. Because of a lack of resources dedicated to an adaptable learning environment, an estimated 90% of students will suffer irreversible educational deficit. Many students during the pandemic were in situations that did not allow for adequate education. The current generation of students have lost $17 trillion in lifetime earnings. This is equivalent to 14% of today's global GDP. Inequity has focused more on females, underrepresented minorities, and the underprivileged. Globally, many females are at increased risk of never returning to school. 10 million females are now at risk of early marriage due to the pandemic, and there has been a sharp increase in gender-based violence. Job loss has been alarming, and women have lost jobs at a much higher rate than men. 39% of today's global workforce are women, and 54% of the newly unemployed were women. Poverty and inequity are hitting hardest those who were already disadvantaged: females, minorities, the impoverished, and children. And as said succinctly by the leader of the Shipibo Konibo community, if COVID doesn't kill me, hunger will. In America, we saw a rapid rise in food insecurity, and it particularly hit our children the hardest. Poverty and school closings played a role in depriving children of consistent meals. Child food insecurity rose from 15% to 25% in the early stages of the pandemic. But science has been doing its best to fight this global insecurity. There has been 33 COVID-19 vaccines with either full authorization or emergency use approval. All of this in a very short period. This chart shows a timeline of when a disease was discovered to when a vaccine was licensed in the United States. The leftmost side dates back to 1880, and the right side is 2020. The bar length is time from discovery to licensure. COVID-19 is highlighted on the bottom. The vaccine development has been remarkably efficient and thorough. I will not get into vaccine specifics during this lecture, but the message is clear. The COVID-19 vaccine development has been one of the most impressive displays of global science the world has ever seen. The vaccine has been a great tool in our armamentorium, but as you all know, we have not only been battling the virus, but misinformation as well. Unfortunately, politicians, social media, word of mouth can all be sources of mistruths, and people's beliefs are shaped by these sources. But beliefs are just beliefs, and science is what we need to spread. We, as scientists, need to make it clear that we are following the data. As Dr. Virchow said, belief begins where science leaves off and ends where science begins. In addition to food insecurity, basic medical care has been affected by inequity and loss of access to healthcare. Routine childhood vaccination rates have dropped both domestically and worldwide during the pandemic. Children's health has been affected by COVID beyond acute infections. And it's not just our children's health that has been affected. Globally, 10.5 million children have lost a parent or a caregiver due to COVID. Worldwide, children have experienced violence, hunger, educational deficit, and loss of loved ones. The burden of stress is at unhealthy levels. Prevalence of depression symptoms in the US was more than threefold higher during COVID-19 compared with before the pandemic. Individuals with lower social and economic resources and greater exposure to stressors like job loss reported a greater burden of depression symptoms. And adult stressors go hand in hand with that of children. The latest global burden of disease study shows that the pandemic has affected the mental health of young people and that they are disproportionately at risk of suicidal and self-harming behaviors. This is affecting all children, even those previously deemed healthy. With people with pre-existing mental disorders did not even appear to be disproportionately vulnerable to COVID-19 causing stress. This is affecting everyone. But people with pre-existing mental disorders have suffered more severe illnesses than those who did not have those pre-existing disorders. The information we have now about the impact of COVID-19 on the world's mental health is just the tip of the iceberg. We've now talked a lot about how COVID became a global pandemic and how it has touched many aspects of life. So how does this all play into long COVID? This was a really big setup. Well, the stress that COVID has placed on the world is now a setup for the development of long-term symptoms. Studies have shown that depression, anxiety, stress, loneliness, and worry about COVID-19 are prospectively associated with an estimated 1.5-fold increased risk of post-COVID-19 conditions. These post-COVID conditions and these mental health concerns lead to impairment of daily life. The CDC Census Household Pulse Survey about long COVID gives a better understanding of the condition's prevalence. This report assesses the labor market impact and economic burden of long COVID. It finds that around 16 million working age Americans have long COVID today. Of those, 2 to 4 million people are out of work due to long COVID. The annual cost of these wages alone is $170 billion a year, and potentially as high as $230 billion. The issue is most of the post-COVID data are in adults. We have very little and very conflicting data on post-COVID unwellness in children. So now to recap, our world was unprepared to deal with a global pandemic. Economic, healthcare, and educational insecurity has led to inequity and increased global stress. Global stress and unpreparedness either leads to or exposes a post-COVID unwellness. All right, question time again. Which patient has post-COVID unwellness? An 8-year-old heart transplant patient who is ventilator dependent after acute COVID-19 pneumonia 2 weeks ago. B, a 7-year-old patient presenting to the ED with a high CRP, high troponins, fever, polymorphous rash, and oral ulcers 4 weeks after acute COVID-19. C, a 12-year-old patient with shortness of breath and chest pain 4 to 8 weeks after acute COVID. Or D, a 13-year-old patient with suicidal ideations and fatigue for 3 years, which has been increased in frequency since March of 2020. I'll give you some time to answer. So by definition, C is probably the right answer. And it sounds like about half of you agree with me. However, let's look at the other choices. The patient in answer A on a ventilator will likely have decreased lung function and cough for quite some time if they recover. B, the kid with signs of inflammation likely has MIS-C. But what happens when they come to your clinic with exercise intolerance due to myocarditis? The patient in answer D has psychiatric symptoms that have worsened during the pandemic. What's to say that the stress of COVID on the world did not cause that worsening? All of these children are at risk for prolonged symptoms due to COVID-19. There are huge amounts of patients that need long-term help because of COVID. Does it really matter if they reach official long COVID diagnostic criteria? Will the management change? And to that point, is management for long COVID in children the same as in all patients? These are issues that we've aimed to try to clear up. So what is post-COVID unwellness? Most post-COVID studies have focused on adults. They have aimed to qualify and categorize long COVID as well as discover the etiology. Often, the definitions of post-COVID syndromes can be broad and they can be vague. We do have some official definitions proposed by the CDC, the NIH, and the WHO. The CDC and NIH define long COVID as new, persistent, or evolving symptoms starting 4 or more weeks after an initial COVID infection. The WHO says that long COVID is when symptoms begin within 3 months after an acute COVID infection and last for at least 2 months. These are different but very overlapping definitions. However, the fact that there is a difference between them makes epidemiologic analysis difficult. The symptoms and post-COVID syndromes have mostly been described in adults and can be many different things, but most often they are described as fatigue, dyspnea, headache, cognitive impairment, sleep disturbances, and anxiety and depression. So what causes post-COVID unwellness? Well, the answer is new, because it's a new question, and the answer is very unclear. If any of you have the answer to this question, I am all ears, and you should email me and we should probably publish together. Humans are a complex ecology of pathogens, host defenses, and tissue biology. There are a few theories about how post-COVID syndrome comes to be, but the theories are based on limited data and mostly regarding adults. One possible mechanism proposed is that there's a persistence of the virus. A number of studies have shown that the virus is capable of persistence in a wide range of body sites, particularly nerves and other tissues. There is also evidence that SARS-CoV-2 spike proteins have been detected up to 12 months post-acute infection in many tissues of post-COVID syndrome patients. The theory is that this persistence provokes an immune response, which can cause long COVID. Some are exploring the use of antivirals in the treatment of long COVID, but these studies have yet to publish definitive data. Another theory is that COVID destabilizes the immune system and causes persistence of an immune response. There are some data that show patients with long COVID had highly activated innate immune cells, lacked naive T and B cells, and showed elevated expression of type 1 interferon beta and type 3 interferon lambda 1. And those remained persistently high at 8 months after infection, all suggesting that there was persistent response to COVID long after the acute infection subsided. A third idea is that COVID causes vascular damage. There has been chest scans showing pulmonary circulation dysfunction with possible microvascular or endothelial damage in long COVID patients. These are three very different mechanisms, and none have robust conclusive data behind them. And these data are all in adults. The big question for us is, do they apply to children? The answer is likely not, but much more research needs to be done to find out. So what do we do in the meantime? The next question is, who gets long COVID? Is there a specific patient population who is more at risk? Well, those adult studies show that patients who were older, female, or who had severe COVID were more at risk for developing post-COVID symptoms. It is difficult to estimate the prevalence of post-COVID unwellness due to differences in study methodology. But the CDC reports that about 13% of the general population has had post-COVID symptoms 1 month or longer after infection. That number drops to about 2.5% at the 3-month mark after infection, and the more severe infections lead to a higher prevalence of post-COVID symptoms. About 30% of people who were hospitalized for acute COVID-19 had persistent symptoms for 6 months. Okay, I want to pause for a moment and gain some more historical perspective. Here is a graph depicting the excess deaths due to influenza from January 1918 to July 1920, the first 2 years of the influenza pandemic. During the influenza pandemic of 1918, most cities instituted public health restrictions throughout the first and second waves. But in 1920, 2 years into the pandemic, there were little widespread responses to rising cases. The US and the world were very underprepared for a pandemic, and they had limited resources dedicated to rising healthcare demands. The country was tired of flu, and more people were dying. The US was largely unresponsive to the fourth wave of the influenza pandemic. 3 years after flu became widespread, people were still dying at rates similar to the beginning of the pandemic. Here is a graph from the CDC on the daily deaths due to COVID-19 in the US during that same amount of time we just discussed, 2-year period. This graph is from January 2020 to July of 2022. When we look at the trends, there's an obvious similarity. In looking to the flu pandemic of 1918, we can find similarities with COVID in terms of the disruption of global well-being. The historian Howard Phillips wrote in his comprehensive study of the 1918 epidemic in South Africa, the incapacity caused by the flu and its after effects seriously affected the country's economy for some time. In Tanganyika, which is now Tanzania, there was described a post-viral syndrome that triggered the famine of corns. This famine was the worst in a century, and it had occurred after debilitating lethargy from the flu prevented survivors from planting crops during the rainy season at the end of 1918. The post-viral syndrome caused depression, hypothermia, hypotension, and mental apathy for weeks and months. In a recollection by an old man in Malawi in 1973, he referred to 1918 as the year when God was angry. There have been other instances of what was considered to be either a post-viral syndrome or unknown chronic unwellness. In 1889 and 1892, during the Russian flu, there were reported post-infectious neurological sequelae described as neuralgia, neuritis, psychosis, inertia, anxiety, and paranoia. In 1918, there was description of encephalitis lethargica with influenza. In 1935, in Los Angeles, there was an outbreak of atypical poliomyelitis with headache, painful eye movement, GI symptoms, and mental dullness with a normal CSF. In an unproven correlation, there was a high incidence of diphtheria during that time, and 24% of patients had positive diphtheria throat cultures. In 1956, benign myalgic encephalomyelitis was described as headache, myalgia, paresis, and mental symptoms, but there was an absence of fever and no patient mortality. Although recovery was usually complete within 3 months, in a proportion of cases, there were fluctuating myalgias and paresis, and they had waxing and waning remissions and exacerbations. And there was widespread depression, emotional lability, and lack of concentration. The theory at the time was that this was due to an unknown infection. During the late 80s and early 90s, there were reports of debilitating fatigue and cognitive dysfunction in patients for more than 6 months. Chronic fatigue syndrome was initially thought to be after onset of infection. There were initial theories that this could be due to Epstein-Barr virus, but this has not been proven to be the etiology. For all of these examples, direct infectious causation has not been proven, but it's clear that there has been episodic and unknown wellnesses in the past. We have yet to see what COVID will prove, but it is important to gain historical perspective that this is not a novel issue that we are dealing with. And that brings us to COVID-19 and long COVID. What is being done about all of this? In February 2021, the NIH committed over $1 billion to support research into post-COVID on wellness. The aim of this agenda was to evaluate what does the spectrum of recovery from SARS-CoV-2 infection look like across the population. They wanted to find out how many people continue to have symptoms of COVID-19 or even develop new symptoms after acute infection. They were looking at what the underlying biological cause of these prolonged symptoms were, and what makes some people vulnerable to this but not others. And does SARS-CoV-2 infection trigger changes in the body that increase the risk of other conditions such as chronic heart or brain disorders? In April 2022, federal agencies announced an additional government-wide action plan to address post-COVID on wellness. The White House issued a memorandum on addressing the long-term effects of COVID-19, which called for the creation of 2 separate reports in hopes of creating an actionable path forward to address long COVID and its associated conditions. The National Research Action Plan on Long COVID details current research and draws a plan for future study of long COVID. The Services and Supports for Longer-Term Impacts of COVID-19 report describes resources for healthcare workers and those affected by the broader effects of COVID-19. These include the effects of COVID on mental health and substance use, the loss of caregivers and loved ones due to COVID, and it, of course, looks at long COVID. Despite these initiatives, little is known about post-COVID unwellness in children. More than 14 million US children have had COVID, and that number may very well be undercounted. The estimated percentage of children who experience long COVID vary. Regardless, the impact is likely significant because such a large number of children have been infected. Estimates of persisting symptoms in post-COVID patients have mostly been reported from 0 to 27%. Going back to the clinical scenario I proposed at the start of the lecture, if a parent has a 13-year-old child with a multitude of post-COVID symptoms like headache, nausea, exercise intolerance, and brain fog, who should they go see? There is little consensus on how to care for pediatric patients with post-COVID unwellness, and parents are drawing attention to this issue. All of that brings us to what experience have we had with post-COVID syndrome. At the University of Louisville, we aimed to create a space where we can evaluate these children. And since October 2020, our pediatric infectious disease group at Norton Children's Hospital and the University of Louisville School of Medicine has offered a clinic for children who continue to feel unwell long after they recover from acute COVID-19. We knew who we wanted to treat: kids with prolonged COVID symptoms. But what were we going to do to offer that they couldn't get elsewhere? We didn't have a novel therapy, but this was a new and developing disease. So we decided that we can learn and study as we treated. Community providers were notified of the existence of the clinic through email, listservs, television, and print newsletters. And the Norton Children's Medical Group posted about the clinic on their website. The patients must be seen must have proven or strongly suspected COVID-19. They must be beyond the acute phase of illness and have new or lingering symptoms. The requirement for appointment to the clinic is a referral by a primary care provider or another subspecialist. Children can be seen by a PEDS ID specialist as soon as the day after receiving a referral to the post-COVID clinic, and appointments are available in person and via telehealth. The structure of our clinic is unique. Our clinic is housed within our existing pediatric ID clinic, and rather than operating as a multidisciplinary clinic, intake assessments were performed by one of 4 pediatric infectious disease providers. A standardized intake template is used and it asks about the symptoms and severity of each patient's acute COVID-19 illness. It touched on ongoing symptoms that the patient may be currently experiencing, and it went over how long symptoms have lasted. Patients were then asked to complete a modified functional disability inventory with questions that were adjusted to account for pandemic-related changes, such as remote learning. Based on each patient's complaints, the PEDS ID provider would then decide what tests they needed to order, and they would decide what referrals they needed to send out. And those subspecialists that we send referrals to have all agreed to see patients in a very short amount of time. The purpose of the clinic is to provide individualized coordination of care for patients experiencing post-COVID unwellness. Between October 12th, 2020 and December 6, 2021, our post-COVID clinic saw 104 post-COVID unwellness patients. Using our standardized template, follow-up visit notes, and follow-up phone calls, we collected data on the experience our patients had with their disease and our service. The following data that I'm about to talk about was collected by our pediatric ID providers, and the following analysis and figures were produced by our wonderful fellow, Katie Weekly, and our division chief, Dr. Gary Marshall. This data is preliminary, and it's still in the pre-published state. We found that post-COVID unwellness is affecting teenagers much more so than little kids. On the graph shown, the y-axis shows the percentage of patients coming to our post-COVID clinic and our regular ID clinic. The dark bars are our general ID clinic, and the light bars are our post-COVID clinic. Post-COVID patients tended to be older than in our general ID clinic, and most were older than 10 years. There was a median of about 14 years of age, and there wasn't any statistically significance in differences in gender, racial, or payer distributions. The median interval from acute COVID-19 to the first post-COVID clinic visit was a little over 2 months. An increase in referrals was seen 2 months after each COVID wave in the community. The line graph shown represents cases of pediatric COVID in Jefferson County, Kentucky. The bar graph shows patients seen in our post-COVID clinic. Among referred patients, the median time from onset of acute COVID symptoms to the first post-COVID clinic visit was a little over 2 months. Likewise, referrals to the post-COVID clinic spiked approximately 2 months after each wave of COVID-19 in the community. Our referrals increased exactly when we thought that they should. The functional disability inventory that I referenced earlier is a well-established and commonly used measure of physical functioning and disability in youth with chronic pain. It's a validated tool, and it quantifies a disability level in a patient, and it uses a series of patient-responded questions. Well, we modified that question set to fit our clinic's needs, and we asked a standard set of questions regarding activities of daily living to each patient so we can tabulate a disability score. Patients exhibited significant degrees of functional impairment due to post-COVID unwellness, with 54% of post-COVID patients experiencing moderate or severe disability. Here we have a heat map of the diagnostic tests ordered. On the left, in each row, are tests. Each column represents a patient, and a dot shows that that patient received that specific test. Most patients received a CBC, a chemistry panel, and acute phase reactants. Chest radiographs, electrocardiograms, and echocardiograms were also commonly ordered. The map here shows referrals placed from our clinic. Common subspecialty referrals went to neurology, cardiology, pulmonology, physical therapy, and psychiatry. Most patients were referred to at least one subspecialty service, but the number and patterns of referrals varied. After this diagnostic and medical evaluation, 56% of patients received a new diagnosis in the post-COVID period. The most common new diagnoses were anxiety, depression, panic attacks, vasomotor instability, migraines, and asthma. And no children were diagnosed with new severe autoimmune conditions, cardiac problems, or cancers. So here is a symptom map of the 10 most common post-COVID symptoms that we saw. The first column of circles beneath each symptom indicates symptoms on initial presentation to the post-COVID clinic. The second column represents symptoms at last encounter. Green shading indicates that the symptom was present, and red shading indicates that the symptom was not present. The size of the circle represents the sample size. Fatigue or lethargy and headaches were the two most common and most persistent symptoms. Those two, plus exercise intolerance, shortness of breath, and chest pain, all had decrease in prevalence from first encounter to last encounter. We see the same decrease here with myalgias, arthralgias, and abdominal pain, which all get better within the median interval of 5 months. When we look at difficulty concentrating, brain fog, anxiety, depression, behavioral problems, and sleep disturbances, we see a slight increase in prevalence from first to last encounter. And this rise in prevalence may be due to the new symptoms arising between visits in patients that did not initially have those symptoms. Most patients improved over the course of the 6 months. 79% of patients were improved or back to normal. Many attributed their improvement to time, and others said it was due to graduated physical activity regimens we would prescribe. Some thought their improvement was due to rest, and some thought it was due to headache medications. The majority of patients and parents said that they were satisfied with the care that they received in the post-COVID clinic. Many patients were thankful for a caregiver who legitimized their child's symptoms and provided reassurance. Parents also appreciated the individualized approach, and they liked that there was targeted referrals to invested subspecialists. They appreciated the option of telemedicine, and they noted that there was a convenience of having a COVID-19 vaccine available in our clinic. So what did we learn from all of this? Well, if you open doors and hang up a sign for a post-COVID clinic, they will come. The question we asked is who is coming? We found that older children came more than younger ones. There is little evidence of an organic cause of post-COVID unwellness in children, and maybe there is one and maybe there isn't one. And children may very well be different than adults in this respect. The goal of this clinic was not to discover an etiology, but rather to help our community get better. And it worked. Patients were happy with their care. Our model was not a multidisciplinary model. We listened, we cataloged data, and we used rational decisions to rule out other concerns or diagnoses. We then followed up with patients and referred them out if need be. That model worked for us. We helped by validating our patients' concerns. We did not have a novel therapy to provide, but we would encourage healthy lifestyles. Namely, we would encourage increasing physical activity, we would encourage good sleep hygiene, and we would encourage balanced diets. It did not matter if post-COVID in children was a real thing or not. The stress that COVID placed on the world opened a door for us to see patients who needed to be seen. Some of our patients likely had symptoms due to COVID, but certainly some of them may have felt unwell regardless of the virus. But our ability to refocus their attention away from the stress of feeling bad and to reassure them that they would improve allowed for proper rehab. And in general, patients got better. What can we do as an individual provider regarding long COVID? Well, we need to offer care to those who need it. COVID may or may not be an organic cause of long-term unwellness in children. But by seeing patients who are struggling, by ruling out other diagnoses and then reassuring them that they will improve, we can help those in need. People tend to trust their medical providers. People tend to trust us more than many other professions considered to be leaders. The graph shown here depicts public confidence in different fields of service. Confidence in medical scientists garnered the highest marks. We have a lot of power and a lot of responsibility. Now, what did we all just learn? COVID caused a major disruption in the world's well-being. Children were no exception to this stress. The pandemic allowed for us to open our doors to additional patients in our clinic. We do not know if these patients were unwell because of the pandemic or if the pandemic exposed them. We also don't know if post-COVID symptoms have an organic etiology or not. But our post-COVID clinic saw a bunch of patients who improved under our care and were happy with our service. In general, these kids get better, but someone needs to listen, someone needs to care, and patients need to be reassured that they are not alone. Thank you very much. I'm open to any questions.
Thank you so much, Dr. Blatt. It was a fascinating presentation. It was a historical perspective. I found almost like a little bit like PTSD, but it was good to just kind of put that in perspective. And I was really interested in all that you shared about your experience with over 100 patients that came to a post-COVID clinic. We at Phoenix Children's don't have one, but that's why we invited you to tell us what you found. We'll wait for some questions to come in. One of my first questions would be, is there anything known about the effect of vaccination on post-COVID, either for kids or for adults for that matter? Because now I think for the most part, the American population has kind of said, okay, COVID is here. I think people know the vaccine's not going to get rid of it. And so I think one of the biggest, reasons why people might be interested in getting vaccines, in addition to just not wanting to get it again. But if there was anything showing that, getting a vaccine either made your chance of getting long COVID less, or if you've already had it, would it, make it better or worse? Those would be things that people would love to have some hard data on.
Yeah, that's a really great question. So I think we need to break the answer down a little bit between adults and children. There's pretty limited data on whether vaccine prevents post-COVID in children. I think there are some reports that may or may not help, but again, vaccine rates in children aren't very high right now, unfortunately. So it's kind of hard to get that data. Now, the adult data that I presented earlier shows that severe COVID may have a higher risk of people developing long COVID in adults. And so it stands to reason that if you can prevent severe COVID, you may be able to prevent some long COVID. But that severe COVID to long COVID correlation in children isn't as clear as in adults. So I don't think the vaccine would hurt long COVID, that's for sure. It certainly may help. It certainly prevents a lot of severe COVID in children. But that's something that I think still needs to be studied a little bit more.
Okay. And now we've got in the Q&A a good question from our geneticist. He says, do patients with post-COVID unwellness commonly complain of dizziness or lightheadedness with standing? There are some reports of POTS or postural orthostatic tachycardia in adults. Have you seen that in children?
Yeah, absolutely. We have seen some of our patients who complain about dizziness and lightheadedness. Those were less, the symptoms I displayed were put up on the screen were the 10 most common that we saw, but there were certainly some patients that showed those symptoms. We would often send them to neurology, and some of them had underlying neurological issues, and some of them got better with time in the neurology clinic. So it's certainly something we're seeing.
Okay, a couple more questions here. The first one from Dr. Goldman. He says, in your early and present patients, did you find any incidents of other underlying diagnoses that were kind of incidentally discovered not due to COVID?
So yes, there were some diagnoses that were not due to COVID. There was some anxiety and depression symptoms that we found. And those were, so there were, even though most of the patients had a post-COVID diagnosis, a lot of the patients had other diagnoses that were able to be diagnosed because they were seen in our clinic. So like those anxiety and depression diagnoses, they may not have been diagnosed otherwise if they hadn't been seen in our clinic, even if post-COVID didn't cause them.
Okay, here's one from our chief of infectious disease. He says, great talk, thank you. How closely do you work with physical therapy? Do you refer patients to physical therapy, or did you work with them to develop a standard plan that you can provide to patients? We deal with chronic fatigue with coccidiomycosis, and we found that giving patients advice on aerobic exercise does help break the cycle of deconditioning.
Yeah, great question. We did refer to physical therapy in a number of patients, but often with all of our patients, and anyone with any type of fatigue symptoms, we would give them a graduated exercise regimen. So we would, if they had trouble going up a set of stairs, we'd say, try a few of the stairs first, and then gradually increase. We'd have them walk around the block more and more and more as we got further out from their diagnosis. So we did give them exercise regimens to try, and those did seem to help. Certainly some patients may need a more intensive physical therapy regimen, but most of our patients did receive some sort of physical guidance.
Okay, we have one email from an anonymous attendee who just says, will we email contact information? Maybe what we could do is you can email me. I have Dr. Blatt's email, and so just email me with who you are and what your question is, and if it's appropriate and Dr. Blatt's okay, I'll certainly forward it to him, and that way we won't expose his email to everybody right now. Unless you want to put it in the chat, you'd be welcome to. And then another question from one of our local community-based pediatricians. He says, it seems that a regular pediatric office can easily function as your post-COVID clinic in Louisville. Is that right?
It's a good point, right? We didn't use a novel therapy. We just had a bunch of providers that were willing and able to spend the time with these patients and provide good follow-up. And we had really good buy-in with our subspecialists. Yes, a lot of different specialties can do that. That wasn't an infectious disease specific option that we offered. And so if a pediatric office has the time to spend with these post-COVID patients, and they do require a bit of time. I mean, we'd spend an hour on their initial visit and a half an hour on their follow-ups often. And if they can get buy-in that can get good subspecialty, good time period where subspecialists can see the referrals, then I think any office can do this. It's not a unique thing to Louisville, even though I think we did it in a pretty good manner.
Okay. And then Dr. Marshall says there may be some utility in recovery for patients to come see the experts.
Absolutely.
So
Absolutely.
Did you find that the patients that came to see you, were they more receptive to perhaps the same advice that any pediatrician would have given them because you guys were ID docs?
Yeah, we certainly see that with post-COVID, and we see it with other things as well, right? Like a pediatrician may tell a patient the exact right answer and advice and do the same exact workup as we would. But when they come and see the infectious disease specialist, there is sometimes a little bit more credence that they give to the answer we have. Or maybe it's just that they need a second opinion. And maybe it didn't have to be another ID specialist, maybe it could have been another person. But you're right. I do think there is some benefit to having that like subspecialty title for some of these patients. But at the same time, I'm pretty sure most patients trust their pediatricians more than most people they trust in the world. So pediatricians still have a lot of power in this, right? And it's a communal effort. Even if someone gets referred to our post-COVID clinic, the pediatrician started the workup, right? They started that conversation with the parents. And that's a really important part of this. Parents aren't going to be willing to listen to us unless the pediatrician says that there's something that we can help them with.
Mm-hmm. Okay. And another question for me, just out of curiosity, is what your algorithm and the functional scores that you use, is that out there somewhere so that if even a general pediatrician or anybody here in Phoenix wanted to kind of like copycat what you all did in your clinic, is that easily available? And if so, how would we find that?
So there is a functional disability inventory score that we based our clinic's questionnaire on. And that is published data. And we modified that question set. We are still in the preliminary stages of analyzing our data, and our fellow Dr. Weekly is working on that. So that's something that I have to ask her in terms of the publishability and what's exposed right now. But we did come up with our own question set, and that is based off an existing questionnaire that is in the data.
Okay. And then another question this one is from our IRB physician. He said, was an IRB submission approved before the research data was collected?
It was, yes. We had IRB approval from the start. When COVID started, for our group and for many groups, COVID, when you have a new disease out there, it really turned us on to the idea that we can learn a lot from what we do. We can be pioneers. And when post-COVID started becoming a thing, from the very beginning, we figured that we can be some of the people to help contribute to that initial data set. And so from the very beginning of our clinic, we sought IRB approval so we can try to standardize our practice and study how effective it was.
Okay. Well, thank you. I really commend you guys for the work that you've done. I think it's going to be helpful not only for us in Phoenix, but for anybody who out there who reads whatever you publish and go on to present later this month. For everybody in our audience, we are recording all of our grand rounds now, and on the PCH CME portal, on the main website, you can find it. This one we're going to keep private until late October because the data that Dr. Blatt shared with us today is going to be presented there, and we don't want anybody to get it leaked. And then by the end of October, we'll make it public with the other documents. But I believe you can still get to it if there's some part that you missed and you want to go to our CME portal today.
Yeah,
and with that,
I really am happy to answer questions too. So
okay.
After the lecture.
Okay. Well, if you want to, I'll give you. If you want to type your email really quick into the group chat, everybody could take a screenshot, and then we'll. It's 8:30 now, so we'll probably need to close the meeting. And another. Okay, there he's typing his email contact in there, and in case not everybody can see it, I will. Well, I can.
It's just daniel.blatt@louisville.edu. So
Okay, I'll put it in Daniel Blatt Blatt at ed
at louisville.edu.
LOUISVILA.edu. Okay, that's out there. Anybody who wants it, take a quick screenshot of it. And with that, thank you for joining us for Grand Rounds, and we'll see you all next week.